Hospitals. So firstly, thank you for joining today, and thank you for the team from Birmingham City Council for inviting me to do the presentation. So I'm going to start with a small little presentation which I want to keep really informal. So if you've got questions, feel free to ask as we go along. Kind of any hands that go up, the team will let me know, because obviously if I'm sharing my screen, I won't be able to see those. And then at the end of the session, we can have a bit of a discussion as and sort of thoughts and so on about this. So I will start by sharing my screen. So, as I said, my name is Jason Simpson-Theobald. I'm the HIV specialist dietitian at Nottingham University Hospitals. So, the presentation today is going to be surrounding the nutritional implications of chemsex drug use. So, before we start, as with all of the presentations as part of this series for LGBT History Month, these presentations are a safe place where kind of we can exchange ideas and sort of learn from each other, but obviously kind of we request that sort of everyone respects each other's views and are sort of non-judgmental and are inclusive throughout. So what we will cover over sort of the course of the next sort of hour or so is why a dietitian would be interested in this topic, because I'm very mindful that it is a little bit random for a dietitian to be presenting about this. Go over a little bit about what chemsex is and what the drugs are used, and then get on to the sort of more nutrition side of things as to the effects on food intake, the effects on energy expenditure, and practical considerations as well. So firstly, why would a dietitian do research regarding recreational drug use? So I've worked in HIV for about sort of 12 years now, and some of my patients during consultations have highlighted the use of recreational drugs within sort of the chemsex setting, and anecdotally they've reported how it has impacted on their nutritional status. But there is limited evidence, kind of when I've done sort of brief literature searches and so on, focusing on nutrition in this area. So as a way of wanting to improve patient care and actually be able to sort of discuss with my patients with some sort of authority, for want of a better way of putting it, I undertook a scoping review, which is a type of literature search as part of my master's dissertation surrounding this topic, as a way of being able to support my patients better. So a little bit of background on recreational drug use in general. So some of these data are a little bit sort of older now, but particularly with the COVID pandemic, a lot of the sort of studies and so on were sort of put on hold. But the data that was published in 2016 shows that almost 8.5% of all adults had consumed some form of recreational drug in the year prior to the survey. But that increases to 18% in 16 to 24-year-olds. So there is large variation within the different demographics of the population. So the BAME population have a lower drug use than the Caucasian population. The LGBT population was higher than those that identify as heterosexual. Just to note, I deliberately used the term LGBT as opposed to LGBTQIA+ here, because that was what the study authors used. So when presenting the data, I've kept that consistent. So there's lots of speculation as to why the LGBT population uses more recreational drugs than the heterosexual cisgendered counterparts. A lot surrounding sort of internalized homophobia and internalized transphobia, sort of difficulties coming to terms with sexuality and gender identity and so forth. There's also good evidence that people living with HIV have a higher recreational drug use than those that are HIV negative. So as I say, that is kind of recreational drugs in general, but moving on to chemsex more specifically. So one of the most widely acknowledged definitions comes from, ironically, called the Chemsex study, which was quite a seminal piece of research that happened back in 2014, looking at lots of different factors within chemsex drug use within certain boroughs of London. So the definition has been chemsex has been defined as sex between men that occurs under the influence of drugs taken immediately preceding and or during the sexual setting. So the main drugs that are involved are Mephedrone, GHB and GBL, and Crystal Methamphetamine. So on the subsequent slides, I will go through a little bit more about those. Other definitions have included other recreational drugs within this as well. And more recently, there have been other drugs added that are from the same class as Mephedrone. But I think when people talk about chemsex, sort of generally it is kind of those three drugs that are used. So all of the drugs are stimulants, which increase sexual desire, which is why they're used in a sexual setting. They're often used in combination, which I'll touch on more over subsequent slides, and they can facilitate sexual sessions over extended periods of time, and there's a potential for several or numerous partners during that time. So I wanted to touch on amyl nitrites, colloquially called poppers. Although these aren't considered a recreational drug that's used within chemsex, they are a recreational drug that is quite widely used in a sexual setting with the kind of LGBT population. So they are entirely legal in the UK, and they've even been mentioned in kind of the House of Commons during a debate on recreational drug use. And they're a small bottle of liquid that is inhaled. It gives you a bit of a feeling of a head rush, but only lasts sort of a few minutes, really. So moving on to the main drugs. So mephedrone is often called meow meow, MCAT, plant food and bath salts. Plant food and bath salts tend to be used more kind of across the Atlantic in Canada and America. In the UK, they are it is illegal to use and is classified as a Class B drug. It is an off-white powder that is often either snorted or wrapped up in cigarette paper and swallowed in like a little sort of almost homemade pill, as it were, but they can also be turned into pills, smoked or injected. They're a very, very powerful stimulant and kind of facilitate feelings of euphoria, alertness and increased sociability. They're quite short-lived and only tend to last for around an hour. Moving on to gamma hydroxybutyrate and gamma butyrolactone, which, based on those names, you can see why they're abbreviated to GHB and GBL. So essentially, GBL is the precursor to GHB. So when it's ingested, it is metabolized by the body to GHB. So they're often referred to as obviously GHB or GBL, GBH or liquid ecstasy, despite the fact it having no sort of relation chemically to MDMA, which is ecstasy. It's illegal in the UK and is considered a Class C drug. It is an odorless, colourless liquid and is occasionally used as a powder. It is swallowed or added to a drink, and it has been used in sort of date rape settings as well, because with it being relatively odorless and colourless, it is sort of quite easy to not notice that the drink has been spiked. It is very, it interacts significantly with alcohol, so it should, when it's used, it's generally added to a soft drink. His chemical background is actually a chemical solvent, and has previously been used for things like sort of cleaning the heads of VHS recorders and so on. It's a relaxant and a sedative, but quite uniquely, a small dose of it works as a bit of a stimulant, but if you overdose or take too much of it, it becomes a sedative and can lead to a coma, which again is colloquially called a G-sleep. The difference in dosing between a sort of, I use the term loosely, appropriate dose for kind of the intended effect and the dose for overdose is quite narrow, so there is a risk of sort of accidental overdose. So they lead to feelings of euphoria and reduced inhibitions, and they last around 12 hours. So crystal methamphetamine is the last one, which is probably the most well known out of those from the series of Breaking Bad. That was the drug that they were synthesizing in that. So this is often called either crystal, meth, tina, tea, ice, and crank. Again, ice and crank tend to be used either more in America or Australia as the terms. In the UK, it is illegal and is a Class A drug, and it is incredibly addictive. It is one of the most addictive substances out there. It comes in little crystals, as you can see in the picture, and is smoked in a glass pipe, snorted or taken rectally. When it is taken rectally, it's sometimes referred to as booty bumping. So the reason it's taken rectally is because the inside of the rectum has got lots and lots of blood vessels, so it's quite promptly absorbed into the bloodstream. It leads to feelings of euphoria, alertness, and intense sexual stimulation, and the effects last between 4 and 12 hours, depending on the dose. So the reason that they're often taken in combination with each other is because of the different onset times and the different duration that they last for. So people may take something like the mephedrone to get them high, and then take crystal methamphetamine to keep them high, essentially. So that's why they're often used in combination. So when I did my literature search, I was really surprised about the demographics of the people using these drugs. There was a wide range of sexual orientations, ethnicities, gender identities, and age groups as well. So although they're viewed as chemsex drugs, they are obviously sort of used by others and in other settings. So from the studies that I found in my literature search, the oldest participant was 65 years old, and compared to some sort of stereotypes of other sort of drugs, they are often used by people that are sort of employed and are sort of used more as party drugs, maybe sort of once a month, once every couple of months, rather than sort of a more traditional sort of addiction sort of thing. So that's evidence that in one of the studies that highlighted all of the different demographics, 10% of the study participants earned over $120,000 per year, and bearing in mind that study is now several years old, from 2007. So the impacts that I found with from the studies are sort of broken down into sort of effects on intake and really the effects on expenditure. So very few of the studies, unsurprisingly, focused on nutrition being their primary outcome, and it was more looking at sort of, for want of a better description, the side effects of the drug use. So There was lots of discussion about nausea and vomiting, both during the taking of the drugs, but also as a more sort of come down side effect as well. Bowels, there is lots and lots of sort of variation. Some people found that they ended up with lots of loose stools. Some people found they were constipated. And as kind of I'm sure lots of people will have experienced, kind of when you have an altered bowel habit, it can really impact on your oral intake, and again can cause lots of abdo pain and bloating as well, which again kind of can really impact on people's food intake. So focusing on appetite, which had the most sort of evidence with it. So with Mephedrone, it was reported in up to 81% of users that impacted their appetite. And it was also reported that 14% of people that used GHB reported an increased appetite after stopping, which could sort of lead you to believe that whilst taking the drugs, their appetite was reduced. So the evidence from methamphetamine, there wasn't quite so much evidence out there, and the study that I've quoted there only reported it impacting on kind of 0.04% of the study participants. I did have some concerns about the robustness of that study, and some of the other data that were presented didn't really fit with the trends that one would expect. But because of the type of literature search I conducted, you have to present all of the data that is available without critical appraisal. So one study that I found particularly interesting was the Kirkpatrick study that I've put there, and there's a full list of references at the end of the presentation. So this was a randomized control trial that was single-blinded, so the participants didn't know kind of what drug they were being given. So there was 4 arms. So there was a placebo, so sort of a dummy pill, as it were, a small dose of crystal methamphetamine, a larger dose of crystal methamphetamine, and MDMA, which, as I mentioned earlier, is ecstasy. How they were able to get ethical approval to undertake this study is totally beyond me, but unsurprisingly, it didn't happen in the UK, because I don't think ethics would ever approve a study like this. However, from actually reading it, it was really fascinating. So they essentially put the groups of people in lab conditions, and things like their sleep, physical activity, all of those sort of things were monitored. They also had free access to food throughout the study period. And it was noted that those taking the crystal methamphetamine, regardless of the size of the dose, had a statistically significant reduction in protein, fat, and carbohydrate intake throughout the study period. They also looked at the number of occasions that the participants ate, and those taking the 40 milligram dose only ate on 5.5 occasions, whereas on the placebo they ate 10.1. So that really kind of emphasizes that there can be a notable intake and impact on food intake, because, as I say, the participants had free access to food and were welcome to sort of eat as much as they wished over the course of the period. One thing that I didn't quite appreciate prior to doing this research was that crystal methamphetamine is also used by those who are suffering with eating disorders, and there was several studies, particularly out of Australia, that highlighted the use in bulimia nervosa in particular. So moving on to sort of the flip side, and that's sort of the energy expenditure. So energy expenditure can often be sort of measured using something called metabolic equivalent times. So that's really useful for comparing different intensities of activity. So, so that you can compare sort of the likely intensity of it. So one metabolic equivalent time is the amount of energy used sat at rest. 2 metabolic equivalent times is double the amount of energy used at rest. So as I say, it gives a really good way of being able to sort of compare activities and give you an idea as to how much kind of energy a person is likely to be using. So as kind of one would expect in a study involving chemsex drugs, sex was mentioned quite a bit. So of the studies I found, 43.5% mentioned use in this context, which, to be honest, I was surprised that it wasn't higher, because certainly prior to doing the research, my mind was very much these are chemsex drugs, so kind of would be used in a sexual setting, but alas, they are used sort of for other reasons as well. So sexual activity has an increased energy expenditure, and that can vary between 1.3 and 2.8 metabolic equivalent times, depending on kind of the specifics of the activities that you're getting up to. So one of the qualitative studies that interviewed lots of participants that using these drugs within a chemsex setting is quoted there, and says kind of when he uses methamphetamine, he literally lies in a bed in a hotel, bathhouse, or his own house, and barely drinks any liquids or eats, and that might be for 24 hours. He has total focus on just having sex, and nothing else matters. So that is demonstrating sort of both aspects, that not only is he having quite a bit of sex over a sort of protracted period of time, but also, regardless of whether it is affecting his appetite or not, he's not eating and drinking so much, because essentially his sort of priority is on having sex rather than eating and drinking. So, as I mentioned, these drugs are also used elsewhere. So GHB was used by about a third of users within a sort of clubbing setting. And the reason cited for doing that is much like taking ecstasy, it increases your stamina, so you can sort of dance and party for longer. But dancing has a metabolic equivalent time of 7.8. So again, if you're sort of dancing for many, many hours on end, your activity level will be your energy expenditure, sorry, will be notably increased. And again, bearing in mind that the GHB interacts with alcohol, so you're not going to be sort of making up for the calories by drinking lots of alcohol, as kind of other settings may have. So it can recreational drugs can also really affect dentition. So crystal meth in particular can really affect food intake. And I apologise for this picture over lunchtime, so I'm sorry if you're eating. So it is again often referred to as meth mouth. So the reason it has such an impact on dentition is that the smoke from it is incredibly acidic, so causes sort of rotting and decay of the enamel, and can obviously cause lots of really sort of painful teeth, and as you can see in the picture, sort of tooth loss as well. So jaw clenching was also reported by 89% of mephedrone users, and that can have a really big impact on food intake as well, because particularly if you've been sort of clenching your jaw for hours on end, it can make sort of chewing significantly harder. GHB tends to cause a dry mouth compared to those that don't use the drug, and likewise methamphetamine being sort of one of the worst there. So although there isn't any specific evidence regarding sort of the dry mouth and recreational drug use and the impact on oral intake, we've seen from research in sort of other areas such as side effects of chemotherapy and radiotherapy that causes dry mouth. Dry mouth can really impact on a person's food intake. And methamphetamine in particular is likely to cause changes in taste as well. And again, particularly kind of research from the oncology setting really highlights the fact that when people have altered taste and are eating food that doesn't taste like they expect it should, it can really reduce the food intake there. So the other thing to keep an eye on and be mindful of is hydration. So up to sort of 81% of mephedrone users reported excessive sweating, and that is sort of sweating beyond what you would expect kind of during the sort of the clubbing or having sex or whatever. And they can be sort of really drenching sweats. One study reported that 8.5% of methamphetamine users reported dehydration, and there's been a couple of case series of people being admitted to emergency departments in America that have ended up in acute kidney injury following mephedrone use. Although this was never mentioned within any of the studies, it should also be sort of borne in mind that when we sweat, we lose lots of electrolytes and salts in that sweat. So that can also have a physiological impact as well. So there's also sort of practical considerations to consider. And although these weren't necessarily identified in the studies kind of that I've found, they've either been raised by patients over the course of my clinical practice, or kind of obviously I've spent quite a significant time thinking about this while I was writing my dissertation. These sort of things have come up sort of in my mind that should also be considered. So depending on the setting that they're used in, there might not be any sort of food and drink available. So, for example, some of the sex on premises scene venues, such as sort of saunas and bathhouses and so on, there might not be any sort of food and drink availability. Or if it's indeed in a private residence, yes, you might have sort of access to fluids, but you're not really going to sort of nip to the kitchen and start cooking. And equally, there's also the safety concerns of things like cooking whilst under the influence of recreational drugs. There's also the consideration of the food and drink not being a priority, even if it were available. So some medications require food to be taken with them. So particularly, there are some classes of HIV medication that require taking food to help promote absorption. So in that study that I've used a quote from sort of on a previous slide, there was discussion how some patients weren't taking their HIV medications because they've been told that they have to eat with them. They weren't eating, so therefore weren't taking their HIV medications. So that has lots of concerns for me as an HIV clinician, because not only are you not having the food, but it also means that you're not taking your HIV medication, and particularly during a time whereby you're potentially having sex with multiple partners. If you're not adhering to the HIV medication, there is a risk of your HIV viral load increasing, and therefore risk of transmission to others. Yes, kind of it's widely acknowledged that when patients are undetectable, they're untransmissible, but that only comes with very good adherence to medications. So to move on to sort of aside from that, I have sometimes suggested to my patients who are attending sort of chemsex parties to perhaps take some over-the-counter supplements with them, so things like nutriment and things like that, or even things like Slim Fast, because nutritionally there's still a decent amount of calories and protein in there. However, there is a class of antiretrovirals, so HIV medication, called integrase inhibitors, whereby the minerals within the supplements interact with with those medications, again reducing the absorption, which increases the risk of kind of virological failure and again HIV transmission. So although kind of on paper having something like a nutriment or something like that would be quite a handy way to have that, to have some nutrition, there are sort of considerations depending on sort of concurrent medications as well. So it has also sort of occurred to me, because I've had a few patients that are diabetic, the practical considerations of checking your blood sugar, particularly if you're on insulin, because when you break down how you go about checking a blood sugar level and then sort of responding to that, it's quite a sort of complex process, which when you're under the influence of drugs can be sort of a lot more difficult. There is also the consideration that if you're having to do a capillary blood glucose level, so kind of what we would previously have said, sort of finger prick testing, then there is also the risk of bloodborne virus transmissions, so things like HIV, Hep C and Hep B as well. I know there's increasing sort of use of sort of sensors to monitor blood sugars, but unfortunately they're not sort of ubiquitously used. So again, that's something that unfortunately I don't have an answer to, how kind of we would manage that. And although we would suggest things like sort of waterproof dressings and gloves and things like that, the kind of, again, the likelihood of someone using those sort of things whilst under the influence of drugs is relatively kind of minimal. There's also the risk of sort of impacting nutrition by the fasting before partying. So those that are likely to be partying for sort of a prolonged period of time, sort of for the full weekend or whatever, may not eat for a period beforehand. So particularly those that intend to have receptive anal intercourse may not wish to eat in sort of the day or so prior to going to the chemsex party, because they're wanting to sort of maintain what they consider sort of being clean. So once they have douched or sort of rectally irrigated, they're not going to want sort of more food going in and therefore sort of coming out again. So not only is there the period of time whereby they're sort of on the influence of, under the influence of drugs, there's also sort of the build up to it as well. So so essentially anyone can use recreational drugs. So I now ask all of my patients with if they take any recreational drugs. I do that sort of pretty much across the board, particularly in the outpatient setting. There is sort of variable degrees of occurrence of all the symptoms that I previously mentioned across the different drugs and different study designs, but quite sort of consistently throughout all of the studies, the drugs do affect the food intake, your energy expenditure, and impact your dentition and hydration. So before I stop sharing my screen, wanted to sort of highlight the rest of the presentations and webinars for LGBTQ+ History Month.